I think, again, in the interest of time, maybe what we'll do is we'll just push on. Now we're going to invite Robert Dowie up to the podium. Robert's the Senior Director of Cardiac Angiography with Siemens Healthcare, to speak on behalf of Siemens regarding regarding innovations in pediatric imaging. Robert's a good South African man and follows a funny sport called rugby, which many of you will know much about. But and in fact, maybe Dr. Hijazi will give us a quick update on the football score between the Patriots and the Ravens. Just
third quarter, 14-13. Ravens, Sharon, are leading. I would not be surprised if the two brothers, the coaches, will meet for the Super Bowl. We have one more quarter and a couple of more minutes. Robert.
Well, thank you very much. I would like to echo the comments of the earlier speakers. I think this is a very useful forum, very interesting, a lot of great information shared. It's always very rewarding for somebody who represents an imaging vendor to see how these tools are utilized to guide clinical procedures. So thank you very much for that. Only financial disclosure I have to make is that I work for Siemens, which is 100% responsible for my income. So I'm going to change the focus a little bit. Clearly, I don't have a lot of clinical images to show you, and we've had such a tremendous showing of that so far. But I'm going to talk a little bit more from the standpoint of an imaging vendor and what we see as our priorities when it comes to the development of imaging equipment. And I really like the comment Dr. Cheatham made about the importance of engineers and clinicians speaking together and the engineers actually listening. And I hope that by the end of this talk, Dr. Cheatham would also concede that maybe Siemens listened a little bit as well and came up with some good ideas from clinical input. I think when it comes to imaging equipment, particularly for the pediatric interventional world, one of the highest priorities is always image quality. I think that we always strive to give the best possible image quality. Radiation dose reduction, obviously very critical, so we could always enhance image quality, but we just can't afford to do that at the cost of additional radiation dose. We also always have to think of the mechanical design and the type of and size of patients that you're treating, access to the patients, and covering actually a broad range of patient sizes in your case, from the very tiny babies to the much older patients. Things like the size of the detector become critical in that kind of equation. And then, of course, enhancements in C-arm-based 3D applications, the import of pre-procedural imaging data and registration with the 2D fluoro. As I said, we've seen a lot of examples of that. So my primary focus is really going to be on these two topics: optimized image quality, radiation dose reduction, and then the monitoring and reporting of radiation dose. So I'm very happy to introduce to the pediatric cardiology market this evening a new innovation from Siemens. This is a new platform which we've introduced. It's referred to as the ARTIS Q and the ARTIS Q.Zen. I have to make the disclaimer here that this is currently under FDA review and is not for sale in the United States, although it has been launched on a worldwide basis. It's an important distinction to make. And the fundamental underlying objective of this platform, which has been in the making now for about 5 years, was really to enhance image quality while keeping radiation dose very low. And I think that that focus probably resonates very well with this audience. There are 3 pillars that are involved in the development of this product, and we refer to them as performance, precision, and sensitivity. Performance relates mostly to the imaging chain, which is completely new. We have a number of new applications, many of them focused on 3D imaging, which is the precision piece of the equation. And then utilizing some brand new technology for angiographic imaging. The sensitivity is based on new technology for image detectors. So first of all, to focus a little bit on image quality. As I mentioned, there's a completely new image chain, and the engine of any image chain is the X-ray tube. So we've introduced a new X-ray tube that we refer to as the Gigalix. It's hard to get really excited about an X-ray tube, so I'm going to try and put it into some terms that are more meaningful. First of all, I think anybody who's into photography knows that if you really close the aperture of the camera, you're more likely to get a better depth of field, and you can have better representation of fine detail. So something which Siemens does, which is somewhat unique, is we don't use the traditional filament for generating the electron beam that results ultimately in the radiation beam after it strikes the anode. We use a flat emitter technology, and you can just see by the representation of the glowing flat emitter versus the filament, it makes for a much smaller focal spot and also a much squarer shape. So the idea there obviously is to be able to represent small details. Also, the loading of that flat detector or that flat emitter is significantly higher than the traditional filament, and it has the added benefit of not burning through like a filament would. So the longevity of the X-ray tube is something we don't have data on yet because we haven't really got a lot of experience with it, but we're very optimistic it's going to be good. This is also an X-ray tube with a much higher output capability, very significant in the case of fast-moving structures, which is clearly what you're dealing with in your imaging, because in order to get enough exposure to the object that you're imaging, you can do that in a shorter period of time, but with a higher amplitude. And to give you a sense of how that translates, some engineering type images, but these are a comparison of the filament tube to the flat emitter tube, and also the longer pulse width versus the shorter, sharper pulse. And you get a sense of the ability to freeze motion and also to just get better spatial representation. The significance of having higher output from the X-ray tube is that you can really tweak this energy spectrum that goes to making up the radiation pulse. So if you look at these images, which are unfortunately once again very much engineering driven, but the green component of that X-ray beam is actually the part which translates to useful image information. But within the spectrum of every X-ray pulse, we also have components that either, on the low energy side, which are either just absorbed by the patient and don't give any valuable contribution to the image, or on the high energy side, they simply go through the patient and the detector and also don't translate to any benefit in the image. So the objective is to narrow down that pulse so that the vast majority of it is just the green part of the pulse. And we can do that by introducing more filtration for the lower energy part of the spectrum and reducing the kV to get to eliminate the high energy part of that spectrum. So you get a much more efficient radiation pulse, which then has obviously the benefit of reducing overall radiation to the patient and to the operators. The second component within that imaging chain, and I think this is really exciting for your particular patient population, is a brand new detector using new detector technology, and I'll try to go through that briefly here. And the exciting thing is it translates to the ability to do really ultra low dose imaging due to the sensitivity of that detector. This is what we refer to as the Q.Zen detector. And the fundamental difference is the wafer, the crystalline structure. We're using a crystalline silicon versus the more traditional approach of using amorphous silicon. And when you think of radiation dose and the ability to reduce dose, we always think of the dose per pulse and how much the patient receives and how much the operator receives. But I think where the significance of this very sensitive crystalline silicon structure comes in is when you look at an image, there are always dose-starved components of the same image. Some areas don't have much absorption and you have a very bright part of the image, but when you're trying to manipulate devices behind the spine or the diaphragm or at very steep angles, you always have very dark areas of the image, and I think that's where this technology helps to enhance the image presentation dramatically. A quick comparison to the amorphous silicon, which is what we've used historically for our detectors, and it's a very unstructured layer which is transferring the X-ray beam into signal, versus the crystalline silicon, which is a much more structured. It's grown, the way the crystal is grown, it's a much more uniform structure. So you can just imagine the noise that's generated in this unstructured amorphous silicon layer versus the newer crystalline silicon. In order to compare the two technologies, we look at the distinction between the electronic noise and the valuable signal. If you look at the amorphous silicon detector, this is a 13.4 decibel difference. May not mean a whole lot, but I think when you see it in comparison to the crystalline silicon, which is a 23 decibel. So essentially the noise component in the image is much lower, which really allows you to amplify that more dramatically. Now, this is a dramatically low-dose image, so I don't want you to think this is representative quality, but it was done with the specific objective of looking at an image. This is acquired at 1 nanogray, which nobody in their right mind would be using for acquisition, but it just shows you the representation of what's actually a transeptal needle comparison between these two detectors. On the right-hand side, the crystal silicon detector, so it gives a sense of how you don't lose that needle in the noise, you really get much better representation. So if you look at the dose spectrum, if you were doing just acquisitions, there's a fairly minimal difference between these two technologies. So when you move over to the right-hand side of this graph, but where it really has its impact is when you get into the ultra-low dose range. So this has the promise of being able to dramatically reduce radiation dose without a significant reduction in image quality. And I think, once again, this is something which from my perspective, has the most promise in the pediatric cardiology environment. We also, in introducing this new technology, had to think about what the starting point would be. Instead of changing all of our detectors immediately to the new crystalline silicon structure, we wanted to introduce one size format. We've always had within our portfolio two detectors, one which was what we refer to as a small detector, it's about 9 inch across, and then one which is about 12 by 16 inches, the large detector. And I think there's always this dilemma about which is the optimum size, and we heard quite frequently that it would be useful to have something in between the two. So this is really a detector which is about a 12 by 12 format. I think it's going to allow access to smaller babies, and it's also going to give you the additional coverage with larger patients. At least that's the promise and the hope. Now, we saw some images of this new technology with a biplane system. I wanted to just show you a couple of images with it on what we refer to as the Zigo. This is a single plane system. It's a C-arm outfitted on a robotic arm that can actually reach into the imaging field and then retract away. And the reason I wanted to show it here is because this has some mechanical properties which the biplane doesn't have. It has the ability to rotate at a much higher speed. One of the benefits of this crystalline silicon structure is that you can read the information faster from the surface. So that allows you to increase frame rates, make a higher speed rotation, and still get enough useful information for an effective 3D. So we have an acquisition mode which actually allows you to do a 220-degree arc in 3 seconds. And this is the video that just shows you that motion. The benefit, I think, once again, from the pediatric perspective is the volume of contrast medium you need to inject. Now you're not looking at a 4 or 5 second acquisition, you're actually looking at a 3 second active acquisition. And granted, the protocols typically have the injection starting just before, but there's an overall reduction in the volume of contrast needed. And it's also obviously geared towards motion. I don't have any images here representative of pediatric patients, and I think you don't actually have that motion issue because you ventilate your patients and you can freeze the breathing motion, but just some ideas of how you can also deal with motion, and at least for older patients, you have to hold their breath. The breath hold time is not as significant. So that's the 100-mile-an-hour high-level overview of this new technology platform, and I hope you'll be seeing and hearing more of it in the not-too-distant future. I wanted to also just touch on some elements relative to radiation dose, mainly on the use of guidance tools during the procedure and the capture of the information for post-procedural use. So we have a whole spectrum of radiation dose-focused features which we have introduced over the years, and this left-hand column, which really refers to dose saving, I'm going to bypass that for just now and just talk more about the monitoring and the reporting side. So on the monitoring side, we have a couple of features we've introduced which I think are useful. The first one is the ability to set user-defined skin dose thresholds. And once you reach that threshold, the system's going to give you an audible warning as well as a visual warning to let you know that you've exceeded the threshold and you may want to consider another projection. And this takes it a step further. This is what we refer to as care monitor, and it looks very similar to some of the future technology I think we can anticipate from Toshiba. But this is basically giving you an angle-specific representation of the dose that the patients received. So as you're doing an interventional procedure, you can make a decision at some point based on the cumulative dose received at that angle to change the angle. It resets that measurement device and starts counting again. If you go back to your original angle, it's going to place you where you were before you left that angle. So it remembers the dose acquired in any projection and gives you an active tool to really think about where the patient's skin dose has been maximized and gives you the opportunity to select a different projection. So you get this gas gauge kind of indication of the dose as you're changing the C-arm angulation. The other thing which is kind of useful is the ability to take this information and store it either together with the patient images when they're archived. So I think we're seeing a lot of pressure from regulatory organizations to start recording radiation dose. So obviously that helps with that compliance. So we use this structured reporting approach to saving the dose data together with the images. But we also take that a step further and say, okay, it's one thing to be able to record the dose together with the patient images, but that goes into an archive somewhere. And if you have these frequent flyer patients who are coming back on a regular basis and you really want to see their radiation dose over the history of their procedures, that's not tremendously helpful. So we've introduced a product we call Care Analytics, which takes it a step further, and it allows you to capture the historic dose information for a patient, and not only from the angiographic lab, but also from CT systems and radiography systems. And it puts it into any kind of a standard database format so that you can look across patient populations, you can look across certain procedure types, and more importantly, when a patient comes back for multiple interventions, you can see historically what the dose that patient's received over their lifetime. So these are just some of the tools that we're introducing to help comply with regulatory guidelines, but also to help you make decisions in terms of the treatment of your patients, especially the youngest ones. Some of the types of searches that you can do with regard to this information. And I think I've achieved a first amongst the speakers this evening. I've finished inside of the allotted time. Thank you very much.
All right, great. We want to invite the speakers here to the podium for a few minutes discussion. So Evan, John, Lee, John, and Tom, and that's it, I think. Please come to the podium here. And Dr. Wilson, as usual, he will start with his first question. The score is 21-13 in the fourth quarter. Oh, 28. It's going to be the brothers. It's going to be the brothers.
The fat lady is just gargling, I think. Actually, I've got two questions. Robert, that was terrific, and thank you for, if you like, taking the mantle of industry and telling us the direction of at least Siemens anyway. But I want to be a bit more futuristic. We have seen some spectacular images, and they're going to augment our interventions tremendously, no doubt about it. And I have to be honest, I really haven't used these rotational angiographic tools yet. But we still need cath labs that you could argue are needing to get bigger and bigger and bigger. And, we're sort of tennis court size cath labs now. Where's the miniaturization? We can buy an ultrasound machine that's, about the size of a tablet. Okay, not a mobile phone quite yet, but maybe you can. So why isn't X-ray miniaturizing too?
So thanks very much for acknowledging I was somewhat a fish out of water here, but actually...
No, you weren't a fish out of water at all. You spoke very well, Robert, and I acknowledge you taking that mantle.
Thank you very much. Yeah, actually, you're right. The guidelines for interventional procedure rooms, particularly when you get more to the hybrid OR kind of environment, are really increasing dramatically. I think what was a very lavish space of 800 square feet some years ago is now sort of 1,200. But this is more a function of the different types of procedures that are being performed in the room, and it's all of the setup rigmarole that goes around the system. It's not really a function of the system. On the other hand, the imaging systems there's more and more 3D imaging, which means rotational acquisitions. This means you need a more and more robust mechanical design, and I think when you see this 100 degrees per second rotation on the Zigo, this required a redesign of the C-arm, so I'm not so sure that I could be really that optimistic about much miniaturization. If you look at the electronics behind it, so the equipment room where the cabinets are, that's definitely diminishing over time because the components are shrinking. But in terms of the mechanics of the C-arm, I don't really anticipate much reduction in that.
I'm disappointed. John.
But your feedback will be duly noted.
I'm disappointed. John. You have a lot of kit in your lab. You must be desperate to get some of it a bit smaller, make life slightly easier, not take up so much room.
Yeah, no, I actually, I agree with what Robert said. I don't think it's not the equipment that takes up the room of the procedures anymore. Certainly, over at OSU with the TAVR and all of the other things that are going on, it's just a slew of people that are in the room, different disciplines that take up the room. Most of those rooms are all single plane anyway, and it really isn't. And as I showed you in the one, you can have a ceiling-mounted system that's out of the way. I mean, it's not a part of the room for a long time. So I don't think the miniaturization is just going to happen. I realize that it won't be the 450 square foot typical cath lab where you could jimmy rig a biplane system in and nobody move around. It's not that. It's the fact that the number of people and instruments and machines and everything that come into the lab now are going to dictate the size. It won't be the X-ray equipment.
Yeah, sure, but you and me and Jackie's not going to get much. We're not going to get any smaller, so we've got to make the equipment smaller. I've got another question. We've seen, again, terrific images, but they've largely been of aorta, pulmonary arteries, and we've seen how rapid right ventricular pacing seems to enhance structures. I think maybe Dr. Carroll's the best to answer my next question. I still do a fair amount of structural intervention, and the one I have in mind is left atrial appendage closure. And to me, a patient in atrial fibrillation, this would be a perfect patient to image with rotational angiography when you're wanting to get morphology and dimensions of the left atrial appendage. What can you tell me about that?
I think your observation, Neil, that the 3D rotational angiography and the output of a 3D reconstruction is currently best done in relatively non-moving structures. So you can use all those images that are required in whatever arc, at whatever frame rate to perform the reconstruction. But if it is an inherently more dynamic structure that's changing shape and size during the entire rotation, then the only way you could derive a dynamic or 4D reconstruction would to be performing some sort of gating, selecting images to reconstruct at the same time point. But that then reduces the number of frames that would go into a 3D reconstruction at one time point rather dramatically, and image quality drops. And so at this point, you have a choice of you can stop a moving object from changing size and shape, and rapid pacing basically does that. But does
But John,
the output...
My point is a left atrial appendage in a patient with atrial fibrillation isn't changing.
And I'm getting to that. And so that's one way of in the sinus to getting a left atrial appendage. In a fib patient, you do have that, but it's there's still some motion. And whether that corrupts your image enough, we'll see. But I do think you point out an excellent example of an application of 3D RA that makes sense in terms of left atrial appendage. I guess my question is whether that would be worth it versus using a 3D echo approach where you could monitor in real time with no radiation the entire procedure versus just doing one rotational angiogram at the beginning.
Yeah, that's fair. And sorry, I've stolen the microphone. Evan, you spoke quite a bit about the lack of a dynamic image. Why aren't we getting dynamic images? Is it a computational issue, a limit of computational? We can gate. Why aren't we getting dynamic images?
Yeah, I think it's, and other speakers on the panel may have more eloquent answers, but yes, to get dynamic images, we will need to gate. And to gate with the current technology, my understanding is we'll have to increase significantly the acquisition frames, which increases the dose beyond the point where we necessarily want to go at this point. And as Dr. Carroll said, it's actually paradoxical that you lose image quality to some degree. I actually was really interested in the application of bringing 3D echo online into the fluoroscopic images, because I thought where you were going to go, Neil, is when you first, your keen observation that really what we show here are pulmonary arteries and vascular structures. We're not showing cardiac structures. And we have tried. We've tried looking at VSD and ASD and all of these things with 3D RA, and it's clearly, to me, trying to fit a square peg in a round hole. It's the wrong tool. Whereas what Dr. Carroll showed, and working with Seibel and the guys at Cedars, I've been witness to a number of complex mitral procedures for moving structures like the mitral valve, or like rapid flow through ventricular septal defects and the way the interventricular septum changes. I really think that they're really on to something much more than we are with echo than we are with RA. I don't think that's going to be the answer.
Could I just add one quick comment with regard to this gating acquisition mode? This is something which we've offered for some time, and it's been adopted by a few institutions, but for all the stated reasons, it's not the most popular. So in order to get enough projections to get a meaningful data reconstruction, you really have to do multiple sweeps, and so this adds to the acquisition time, which is the biggest challenge. But certainly you can gate, and because the gating on a single sweep doesn't give you enough data points, you have to make 4 or 5 sweeps, so not that well received.
Great. John, you have a question?
Yeah, just very brief comment for Dr. Carroll. And I was thinking maybe you should put your fiduciary marker on the end of a guide wire and stick it in the left atrial appendage to get rid of the problems with translation of the appendage during your angio.
That's a great idea, John. And I think in the next few years we may see a whole new kind of catheters taking a next step that are more echo-friendly, that have an echo signal that can be detected and tracked in real time. But your idea makes a lot of sense too. Are you going to try that? Are you going to do that?
Unfortunately, I don't have a patent.
Huwaida?
Just a question for Evan. You showed that beautiful picture of the LeCompte and with the PA and the aorta. Did you do simultaneous injections, or did you do an injection of each one and overlay them?
We've only looked at, I suppose you could do it either way, but in the interest of radiation saving, we just do simultaneous injections. So the radiation dose basically remains the same or comparable, so it's one spin, and it's just two injectors injecting at the same time, more or less. Tom has shown at other meetings some really beautiful images of sort of complete, you might want to comment on this, more complete structure on the right and left heart by letting dye just flow through the lungs. And so that's another way to sort of obtain relational imaging. But this was just two simultaneous injections.
Yeah, just to expand upon that, because when I talked to Evan about this, we were interested in the same thing, and he had gone through and two injectors and all that, except there's only one injector that can be hooked up to the system that tells it when to inject, and otherwise you time it. So what my guys did, I said, well, this is kind of stupid. So what they did was a single injector that is timed for the spin, and then we just do a Y port. And then as long as you use the same catheter, French size, the same catheter in two different places, it equally distributes the contrast because it's the same flow rate, it's the same resistance, and it just goes into a Y. And the reason we did that was from our perfusion guys, who are always putting little Ys on their perfusion to send the fluid equally. So we just do a one injector now. You go in and, one time, and they're the same pictures. You got to use the same catheter. So whatever the catheter is, use the same one, but it's the same thing. And now we don't have to pull in our other injector. Ralphie never got is Ralph here? Ralphie couldn't get the timing because it's a delay, so you have to anticipate the delay when you're doing it by hand and stuff. So this is a real simple way to do it now.
And what doses are you using? I guess we're really new to this, and I know there's a learning curve.
This is for
how much light contrast and the dilution?
It turns out that, and it's like everything else, as you get more experience with it, you get a little better at it, but it's become rare to be higher than 1 cc per kilo. And as Lee showed, we all do this differently, I think. But there's various recipes, but they mostly all involve diluting the contrast either 1-to-1 or 2-to-1, depending on the structure. The big sort of advancement for us, and we stole it right out of the EP literature where they look at left atriums years before we got this, was rapid pacing. Rapid pacing and slowing down the transit time really allowed us to come way down on our dye load and get good image quality. Just about all the images I showed were significantly diluted contrast. And so again, I think you can do this. We all started with probably higher contrast loads, but you work your way down as you get comfortable with the technology.
It also depends on what kind of acquisition you're interested in. So for the volume-rendered acquisitions, 1-to-1, 1-to-2 is fine, but and you get a nice picture. But if you're interested in the CT quality images with tissue definition, where you want to see the tissue, then you actually use even a lower dilution, like 1-to-3, 1-to-4, to give you the ability to look at tissue and do the segmentation on the CT quality or on the CT program. So it depends on what you're interested in doing. So you can actually see the stent, and you can see the vessel from the CT. You can actually measure the internal dimension of the vessel, see if the stent is adhering to the vessel wall from a CT. So it's just like a CT, but you use a very dilute contrast mixture.
Because Elkin's not here to say this, and I've asked him this question a number of times, Elkin does not dilute at all. He gives a straight contrast injection and you just don't, it's not the same volume that we're giving, and so therefore the flow rate is less. So if you're giving on a 30 kilogram, you're giving 30 mils, it's 30 mils of contrast, but then you have to divide 30, not 60, over the spin. So it's less volume, but the contrast, and he says it's been, I have not done that yet, but he says, you know, we've all seen his pictures, they're beautiful and stuff, so.
Jackie?
Are there any billing codes for rotational 3D reconstruction, and how do you do if you're, you know, you're not doing an RV-gram and a PA-gram, you're doing one image and seeing it all? And are there radiology codes that you can borrow to bill? That's obviously going to help institutions be more supportive of acquiring the
Who's going to take
Yeah,
this question? Tom?
There's two billing codes. One is, the difference is whether you do your post-processing on a separate workstation versus the same one that's basically, I believe it must be the one that actually does the injection. I've never seen a system like that. So we always have it with, you know, post-processing on a separate workstation. So there is a billing code for it. I have no idea how much the reimbursement is.
Okay, I have the last question here. For all of you in your practice every day when you go to the cath lab, do you always start with a 3D angiogram, or you do biplane, and then if you have a problem or you don't understand the anatomy, you proceed to that? Let's start with Lee.
Well, it depends. Yeah, for coarcts, for Glens, and for pre-Fontans where we're injecting. Yeah, we start with the 3D and then work from there.
Yeah, we do the same, and all of the complicated PA rehab, we start with the rotation, then we go straight to the single, a lot of times just a single, not even in biplane, just go to that specific in that angle and then work from there.
Great. Evan?
Mostly the same, but I think it really depends on the case, and it clearly evolves with your experience. You know, so we didn't start that way. So I think if you're starting, it's probably not the way to start with a 3D. The other thing is I still like to get, depending on the case, the hemodynamics before we give a big dye load. So it does change your workflow. So what we like to do is, and this is good for training actually, you get everybody used to getting all your hemodynamics in single plane because you don't like to bring the lateral in and out. And of course it has to be parked for this. So it depends a little bit on how hard the kid is to cath and this and that. But for the most part, for simple things like, let's say, a pulmonary valve implant, yeah, that's the first thing you do, and then you go from there.
Tom?
Yeah, my approach to this actually depends on what the intent of the procedure is. If I know we're going to be doing an intervention in aorta, pulmonary arteries, and especially a small child, stent deliveries, I won't start with a rotation because I'll get initial hemodynamics and initial contrast angiogram of the lesion. The reason being is that, again, it's not real-time imaging, and knowing that after you put a stiff wire in position and, you know, after you've already done your rotation, you may distort the anatomy. So I've gone to actually doing the rotation with a wire in position. You do get some artifact with it, but typically we get more than clear definition of the anatomy if we're planning to use it as a roadmap. If we're just using it for diagnostics, I'll do it up front.
Wait, John?
As pointed out by many, if you're not doing PA interventions, if you're not doing coarcs, the reason to do whole chamber, great vessel rotational angiography is more limited. TAVR is an interesting application. Our main rotational application is doing coronaries. We really think it dramatically and documented in a randomized trial that it reduces radiation contrast and makes the procedure faster. So it's here to stay, and there is a learning curve, and we haven't talked about that, and it's very much getting staff on board because they can make rotations work or not work, getting the wires and the drapes out of the way.
Great. Although I said the last question, but since you stayed here for the whole session, you get a short last question. Go ahead.
Thank you. This is for Mr. Dewey. This question of doing a rotational first and then followed by an AP lateral, it seems to come up a lot, and in a lot of places seem like, regardless of the learning curve, it's still something that's necessary to do. Given that these imaging now is data acquisition from in a digital spectrum, isn't it possible to set the rotational such that it acquires a straight AP at the very beginning in the AP projection, and as the camera is passing through the lateral to 90, so in other words, they're just obtaining slices. Can't those separate images be separated out so you can still see an AP and a lateral from the rotational?
You can, but it's a static image. So you actually, I'm sure everybody here has done that. Maybe not AP and lateral, but you can you can stop if you get 200 or 100 images, however many cuts you have. You can stop on that. So you can stop on AP, and yes, you have an AP image, but it's a static one, kind of like an X-ray with dye on it. So it's not really what you're doing the 2D angiography for.
Great. So we're going to come to the conclusion. I want to thank, of course, the speakers for putting all this together and sharing their expertise. I want to thank all of you for staying that late for this symposium. I want to thank, of course, Siemens, Philips, and Toshiba for sponsoring this. And, of course, I want to thank Damien for arranging this symposium and putting it together. Thank you. And we'll see you at 6 a.m. for the 5K run. Sleep. Don't go out and get a vent now.